you should know about. So basically, the way it's going to work is I'm going to give you a history, and then we'll go through the examination, investigations, and management. And I'll be asking you questions about what you think, what would you request, and things like that. So just interact, please. Give me answers if you think you know the answer, and don't be afraid to tell me what you think. Okay. So yeah, what I said, simulated patient scenarios, all the way from histories to examinations, investigations, and then final management. Okay, so let's start. So you've just started your shift in A&E, and this is the first patient you pick up. So it's a 72-year-old female. She arrived via ambulance, and on the triage sheet, it says that she's been having about a 3-hour history of increasing shortness of breath. She's a known asthmatic, and she says that her blue inhaler, her salbutamol, is not having any effect at the moment. One of the healthcares has very kindly done your obs for you. So she's alert, respiratory rate of 26, heart rate of 120, she hasn't got temperature, BP of 125/85, and her peak flow is 45%. Okay. So before we even see the patient, what are you thinking is going on? Would anybody like to give some suggestions? No? Okay.
Asthma attack.
Okay, yeah. You're on the right line. So sounds like she's having an acute exacerbation of her asthma. That's great. So that's what I'm thinking as well. So acute severe asthma, the three main principles of it are it's a reversible obstruction of the airways with inflammation and mucus. Anybody know any triggers of asthma? Anything that can cause people to have asthma attack?
Cold.
Yep, so upper respiratory tract infections. I've also got here irritants like pollen, fur from animals, stress, exercise, and stress again, because it's really important. Also cold air can cause asthma attacks. So what do we want to get from the history from this patient about their asthma? So shortness of breath, tight chest, wheeze, cough, and what normal treatment are they on? Normal treatment not working. Sorry, I can just hear some feedback. So apart from acute asthma, has anybody got any ideas what other differentials this might be? So I'll go back to the case, and anybody else can think of any other things this might be other than asthma. It's got a raised respiratory rate, raised heart rate. Anybody else got any idea? Okay, right. So this could be heart failure with a raised respiratory rate. Could also be a PE. Could be anaphylaxis, airway obstruction, or maybe even a pneumothorax. But because she's a known asthmatic at the moment, we can think that this might be just an exacerbation of her asthma. Okay, so this is taken from NICE treatment summary on acute asthma. And basically, this is different grades of asthma, going all the way from moderate to near fatal. And as you can see, the peak flow decreases as you go up the scale. And all you need is one of these items to get into the next category above. So if we look at our patients, they have a rest rate of 26, BPM of 120, and they've got a peak flow of 45. So this puts them in this category. We haven't seen them yet, so we don't know whether they're able to speak in complete sentences, but at the moment we're thinking this is probably a severe acute asthma attack. So yeah, that's just highlighted there for you. So it's really good to have a rough idea of these numbers in your mind, so you don't have to look them up, and that enables you to get a rough idea of how badly this person is affected. Okay, so what do you want to do next? So what you want to do next is you want to assess the patient. You want to go and examine them and take a history. So what are you looking for when you examine the patient?
Sorry to briefly interrupt you, Joe. Just so you know, some people are bringing in some answers in the chat.
Oh,
If I'm
sorry.
not saying anything out loud, do have a little look.
Right, let me see if I can.
But yeah, everyone at home, you're welcome to speak out loud or use the chat, whichever you prefer.
Sorry, I didn't know. Okay. Brilliant. Okay, how do I get right? Let's see if I
No,
can.
I can read them out loud for you if you like.
If you could.
Yeah, I'll do that.
Oh, sweet, thanks. Okay. So what are we looking for when we assess the patient?
Any cyanosis?
Yeah, yeah. Anything else?
I've got use of accessory muscles.
Yep, perfect. So
And the breathing rate as well.
Yeah, definitely. So yeah, those are all really important things. So firstly, when you approach the patient, what is their consciousness level like? Are they agitated? Are they tiring? And then looking at signs of exhaustion, like somebody correctly said, cyanosis is really important, use of accessory muscles. And then whilst you're taking your history, you can also assess, are they able to speak in complete sentences? A full respiratory examination is really important. Expose the chest, the front and back, inspect the front and back, chest expansion, auscultation, the whole lot, and a full set of observations again when you see them, and also monitor their peak flow. And when you're taking your history from them, also, if they're able to speak to you, do they take their medications? A lot of patients that I've come across don't always consider inhalers to be medications. So if they give you a list of the tablets they're on, also ask, what inhalers are you on? And also, once they're stable, it's also good to check inhaler technique. A lot of people might not know how to take their inhalers properly. And as a junior doctor, you can be in a really good place to be able to educate people. And also, have they been in before, been into hospital before with exacerbations of their asthma? How unwell have they been? Have they been able to be managed in primary care? Have they had to come in? Have they even been on critical care? So details of things in the past. Okay, so the patient that we're seeing, so because it's an emergency situation, it's always useful to use the A to E approach. So this is what we find. So the airway is patent and they are able to speak in full sentences, but they're very short of breath. They've got widespread wheeze bilaterally, chest expansion is equal, and there's no recession. C for circulation. So they are tachycardic, but heart sounds are normal, and there's no signs of cyanosis. They're a bit tired, but the consciousness level is not deteriorated. It's still 15 out of 15, and exposure is unremarkable. So that's what we found on examination. Just a little side note, if any of the younger years are in, this is how you can draw wheeze in patient notes. So just 2 musical notes. If it's bilateral or unilateral, just put it in the one. And that allows somebody who's flicking through the notes to visualize really clearly without having to go in and read everything. So yeah, that's just a little side note. Okay. So investigations, so yeah, monitor peak flow and O2 saturations to monitor how effective your treatment will be. ABG to see if they're in respiratory acidosis. And whilst chest X-ray isn't routinely done, you can do it. Okay, so here's the blood gas we got from this patient. I've put the normal values in for you. Would anybody like to interpretate that for me? What's going on?
He has respiratory acidosis.
Yep, that's correct. So Yep, the pH is low. They have a low but normal O2. CO2 is high and bicarb is normal. So yeah, this is respiratory acidosis. So this patient has respiratory acidosis. So the management of acute asthma can be done in primary care or it can be done in secondary, depending on how bad it is. If it's moderate, using that guide that I showed you before from the NICE treatment summary, it can be managed in primary care, but anything severe or above needs to be managed in a hospital. So if you're a GP and you're seeing a patient outside of hospital, it's important to obviously examine and treat what you find, but an immediate hospital referral will be required. Does anybody know roughly sort of how you treat acute asthma in a hospital? What do you give?
Do you start off with corticosteroids, oral corticosteroids, and oxygen?
Yeah, so all corticosteroids come in a bit later, but yeah, they're in there, and give oxygen as well. That's important. Anybody can think of anything else?
We've got someone in the chat saying oxygen with back-to-back salbutamol nebs.
Yep. Yeah.
A lot of other oxygens as well.
Oxygen, yeah, that's important. Okay, so as people rightly said, if they're hypoxic, prescribe oxygen and titrate it up to 94, 98, unless they're a known CO2 retainer. The first line treatment is high dose inhaled SABA, such as salbutamol. And if this initial dose that you give is ineffective, consider back-to-back nebs. Poor response to salbutamol, then you can add nebulized ipratropium bromide, 500 micrograms for the adults. And then, as somebody rightly said,
Are you still open? The service, yeah.
Oral steroids. So you can give Pred, 50 milligrams for 5 days. If that's not working after your salbutamol and ipratropium, you can give IV magnesium sulfate as things escalate. If after doing a chest X-ray you see that there's an infective cause of the exacerbation, you can give antibiotics, but this is not routinely done unless you've got evidence of an infection. And if a patient is really tiring and it's starting to become life-threatening, mechanical ventilation can be used if they're going to severe respiratory distress. So that's roughly how it works. I found this on treating people in primary care versus secondary care. And here's some of the reasons why you might want to send somebody to hospital, even though they might have a moderate exacerbation. So if they're a child, if they live alone, if they've had a previous severe asthma attack. So reasons like that to have in the back of your mind if you're in primary care. Okay, so that's the first case. So now you're seeing your second patient. So this is a 44-year-old male. He arrived by ambulance and he was found lying at the bottom of a ladder by a member of the public. He's really agitated and in a lot of pain and is clutching the left side of his chest. Morphine has been given by the paramedics, but he's still in a lot of pain. The observations you've got at the moment are he's alert, respiratory rate of 30, 125 heart rate, BP of 102/60. That should say oxygen saturations of 94% on room air. Okay. So what do you want to do now? So this is an emergency situation. You've got a patient that's, we can suspect from looking at this history that he's had a fall. We don't know how high he's fallen, but we can imagine it's probably about 6 to 10 feet. Nobody was there to witness the fall, but yeah, he seems to be in a lot of pain, and we'll have to have a look at his chest and see what's going on. So if you're in a situation where there's trauma, it's always important to consider the C part of A to E first, because this can be the thing that kills the patient first. Once you're okay that they're not bleeding excessively, and they're not bleeding out, you can carry on with the rest of the A to E as normal. Okay, so in this patient, the C is okay at the moment. So we go back to A and start from the beginning. Okay, so their airway is patent, they're able to speak to you. On B, for breathing, what kinds of things would we be looking for somebody who's had chest trauma? Anybody got any ideas?
You want to check if they have a flail chest?
Yeah, flailed chest maybe. He may have multiple rib fractures. And from the history, he sounds like he's in a lot of pain, so that's definitely a possibility. What other things would we be looking for?
We've got someone suggesting equal chest expansion.
Yeah, really important. If that's unequal, it also suggests that something more sinister is going on.
We've also got breathing rate, accessory muscles, hypoxia, and chest expansion again.
Yeah. So go back to the case. So he's really tachypneic. Yeah, heart rate up, and his O2 sats are a bit low on room air. So yeah, so that's part of the breathing part. As people said, chest expansion, things like that. In this particular situation on auscultation, what might we be looking out for? What's important not to miss? If somebody's had a chest trauma.
I guess pneumothorax would be one.
Yeah, exactly. Yeah, that's what I was getting at. So this patient is very short of breath and they're starting to tire now. So on examination, there seems to be a penetrating wound to the left lower chest. There are absent breath sounds on the left chest, and there is tracheal deviation to the right. Okay? So you need to starting to think about maybe a pneumothorax is going on, and you've got evidence of an injury, penetrating wound, maybe connecting to the pleural cavity, trachea deviating to the right, short of breath. You need to be thinking tension pneumothorax. So what is a tension pneumothorax? Basically, it's where there's a communication between the outside environment and inside the body, the pleural cavity. And what happens is, as you breathe in, normally air goes from your trachea into your lungs. And then when you breathe out, pressure increases due to the diaphragm. Pressure increases inside the lungs and air goes out. However, when you've got this passageway, there's another route for the air to get in. And this flap that's created in between the ribs, when you breathe out, closes up. So that air that enters on inspiration cannot exit. And over time, this air and pressure builds up within the pleural cavity, and that puts pressure on the lungs and all the structures in the mediastinum, like the great vessels. If this continues, you can be in a situation where there's so much pressure being exerted that the patient can go into cardiac arrest. So this is a real emergency that you can't miss, and it can be diagnosed on clinical examination, examining the trachea, listening for breath sounds on auscultation. So just a side note before we go into the case a bit more in detail, can anybody think of any reasons why a trachea would be deviated towards a pathology or deviated away from the pathology? Any ideas for the trachea being pulled towards the side of the pathology. Any examples of diseases that would cause that?
Got a malignancy,
Yeah, definitely.
lobar collapse, pneumonectomy.
Yep. Yep. So, and fibrosis is another one. Anything that would push it away.
Pneumothorax.
Yep, exactly.
Pleural effusions.
Yep, large pleural effusions can cause tracheal deviation as well. So yeah, that's great. Just a bit of a side note, but important stuff. Okay, so the tension pneumothorax. So this needs to be treated urgently. As I said, if you allow this to continue, this patient can go into cardiac arrest. So the clinical examination history should determine whether this is tension. So tracheal deviation away from the tension pneumothorax, reduced or absent breath sounds on the side of the pneumothorax, and then evidence when you're doing your inspection of the chest of injury or rib fractures, and also mechanism of injury from the history can tell you if there's been damage to the ribs. So the most important thing is if you diagnose it clinically and you find it when you assess the patient and you know they've got a tension pneumothorax, you need to treat it then. Don't go to X-ray and get a chest X-ray of it because you're wasting time. Treat it as you find it. Okay. So another important point to make, that always know your limitations. You might know theoretically what to do, but obviously this is a very unstable patient and you need senior support. So the treatment immediately is emergency needle decompression. And you do this in the 5th intercostal space mid-axillary line. That's to equalize the pressure and reduce the pressure inside the pleural cavity immediately. After that's done, a chest drain can be inserted. It's always really important to monitor the obs of these patients really, really carefully and give oxygen as required. When all this is going on, especially if maybe you're in a trauma call and lots of people are running around doing different things, it's easy to forget other injuries the patient have. They might have long bone injuries, other things going on. So assess for other fractures and other injuries once the patient's more stable. Of course, like I said, if you can do it on clinical examination, treat it then. But afterwards, you can do a chest X-ray to make sure that the structures are returning back to where they should be. Or this can be done on ultrasound if a patient isn't able to do a supine chest X-ray. ABG is really important, and then just bloods as well. So that's tension pneumothorax. So I thought it would be interesting just to go through a chest X-ray and interpret it. Obviously, like I said, clinical examination should be able to diagnose this, but it's good principle to interpret chest X-rays. So for image quality, I hope you've all heard of the RIPE. Does anybody know what RIPE stands for when assessing image quality on chest X-rays?
Is it ribs, inspiration, penetration, and exposure?
Yep, perfect.
Rotation.
So, yeah, so this basically allows you to be able to tell how good the film is. So let's have a look at this one. So rotation, it looks like this patient is rotated, probably because it was taken in an emergency. So it is rotated. Usually, you look at the spinous processes and make sure that they're equidistant. But in this patient, they clearly are rotated. Inspiration, you want to see about 5, I think it's anterior ribs on inspiration of the patient. This looks like you can see good inspiration on this film. Projection, I can tell you this is would be a PA on this patient, and exposure. So you should be able to see the spine through the back of the heart. Obviously, the heart is shifted on this X-ray, but in general, that's what you do. So yeah, this is what I said, yeah. Sorry, this film is an AP. So film is rotated, look for the spinous processes. 5 anterior ribs means that you've got a good view of the lung fields. Yeah, AP, and should be able to see the vertebra posterior to the heart. That's how you assess image quality. So interpreting the X-ray, A, B, C, D, E. Does anybody know what each of those stands for?
Airway, breathing, circulation, diaphragm.
Yeah, so yeah, exactly right. So airway, breathing, cardiac, diaphragm, and then everything else. So if we go through this X-ray, looking firstly at airway. So looking at the trachea, is it deviated? Oh yeah, it's deviated to the right here. You can see the bronchi and the hilar are also deviated to the right. For breathing, when we look at the lung fields, we can see a pneumothorax on the left here. And the heart, when we go to C, is also deviated. It's being pushed to the right, that should say. But it's been shifted over because of this tension pneumothorax. Diaphragm can be seen, no air under the diaphragm, and the costophrenic angles are present here. And then when we're looking at everything else, we're looking for fractures. So on this X-ray, I got it off the web, there are fractures in the posterior 3rd, 4th, and 5th ribs here, and yeah, we can see ECG leads as well. So that's just a bit of revision of how to interpret chest X-rays. So final case. So this is an 88-year-old lady on a triage sheet. She came in as getting more confused over the past few days. She has a cough normally, but it's been getting more frequent over the last few days. Her past medical history includes heart failure, hypertension, and she has type 2 diabetes. So observations are she's alert but very confused. She's got a respiratory rate of 24, 88 BPM. Her O2 sats are 90% on room air, 146 over 95 for BP, and 37.5 for a temperature. Okay, so that's the next patient. So as I said before, what would you do next? You go and see the patient. So this patient's really confused, so unfortunately you can't get a history from them, but you can examine them. So as we talked before about a full respiratory examination, what you find is chest expansion to be equal. There's no recession, but there are coarse crackles bilaterally. She's periphery shut down. Heart sounds are normal, and her abdomen is soft and non-tender. Okay, so you got good information from the examination part. So just to clarify how you document this, so abdomen soft and non-tender, just an arrow going straight through it. And then this is how you document coarse crackles widespread bilaterally in the notes. Okay. So how do you think we would get a history for a patient like this? Who would we speak to?
Is it family members or relatives?
Yep, so next of kin. Yep.
Sorry, Joe, we've got someone saying paramedics as well.
Yep, so if they come in via ambulance, they'll get an ambulance sheet. which will be the green sheet that comes with the notes. That's really, really useful information. It'll tell you brief history of the patient, observations that have been done, and if any medications have been given by the paramedics, that will be really useful. Next of kin, family members, also really useful information. So this all comes from collateral history, which is a really, really useful skill to have as a foundation doctor. It allows you to be able to get a good impression of a patient's status without them really being able to tell you themselves. So it gives you an impression of the functional status prior to deterioration. What were they like normally? Have they been eating and drinking? Do they normally live independently, or do they have carers? Do they live in a home? Are the family supportive? Do the family live a long way away? If they live in a care home or a nursing home, details about their health in general. Is their diabetes well controlled? Is their heart failure well controlled? And in this patient, they are confused. So is this new? Is this, do they normally get confused, but this is worse than normal? What specifically about the confusion meant they were brought to hospital? Do they have dementia or signs of dementia? So this is all really useful information to have because you're just seeing a snapshot in time, really. So investigations. So you want to do regular observations on this patient. Because they've got respiratory signs, you want to do an ABG. Okay. Why would we do an FBC in this patient? Just
check for anemia.
Suspect anemia.
Yeah, anemia.
Yep. Anemia. Well, what else would we find on an FBC that would be useful?
You know, like signs of infection.
Yep. So white cells. Yep. Okay. UNEs. Why would we want to do UNEs?
Electrolyte abnormalities.
Yeah. Kidney function, electrolytes, as you say. CRP. What does CRP tell us?
Infection, possibly.
Yep. Lactate. Why would we want to lactate?
Possible sepsis.
Yep. Clotting.
P would be one.
Yeah, it's just a useful in a screen of bloods just to have the clotting to be able to see like the status of the patient now and also when you start treatment. So it's useful to have. Blood cultures.
Infection again.
Yeah.
We've also got someone in the chat talking about curve 65.
Yeah, yeah, perfect. When you're outside of hospital, obviously you can't do the urea, but when you're inside, you can get a urea and you can accurately assess curve 65 and how severe, if they have pneumonia, it is. Yeah, and also a chest X-ray to be able to see what's going on, see if there's any consolidation. So those are the investigations you want to do. With everything going on in the world at the moment, if I just go back to the history, has anybody got any ideas what they think might be going on with this patient? If I tell you they live in a nursing home.
It could be COVID or like pneumonia or
Yeah.
pulmonary edema.
Yeah. Yeah. So they've got heart failure. So the rest rate might be going up because of that. Could be a number of different things. Pneumonia, like you say, COVID. Yeah. So those are all reasonable differentials. So yeah, so COVID-19 at the moment, we've always got to suspect it if patients come in presenting like this. Could be the flu, could be an aspiration pneumonia, could be a very unusual sort of immunosuppressed type pneumonia. So yeah, those are some of the differentials. So obviously, we all know about COVID-19 at the moment. It's the pandemic going on with SARS-CoV-2. And there is a widespread variety of severity of infections, from mild asymptomatic mild flu all the way up to respiratory distress syndrome. So what are the symptoms of COVID-19? Just shout them out.
Cough, shortness of breath, loss of smell.
Yeah. Fever as well. So yeah, these are all the symptoms. In the elderly, they can present slightly differently. With any respiratory illness, they can become confused. And if they're not able to communicate with you, maybe they have dementia, it's really important to pick up on the signs when you're examining them. But yeah, a loss of taste and smell as well. Okay. So management, the one thing you want to do is you want to do a PCR to test to confirm the diagnosis, but this takes time to come back. So it's really important to consider comorbidities. So this patient has heart failure, they have hypertension, and they have type 2 diabetes, which are all important when considering their treatment. So after looking at BMJ best practice, they recommend treatment based on mild, moderate, severe, and critical patients. So it depends on where the patient falls and clinical decision about how to treat them. So in mild COVID-19, it's home care, self-isolation, analgesia, antipyretics, and just supportive treatment, making sure you eat and drink well. Moderate COVID can be treated at home, but it can also be treated in the hospital. Again, analgesia, antipyretics, supportive, and antibiotics can be considered in case they have a bacterial infection alongside. When you get into severe and critical, they must be treated in a hospital. Oxygen therapy, venous thromboembolism prophylaxis, antibiotics, steroids like dexamethasone, remdesivir, and again, pain relief and antipyretics. In critical patients, you do all of the above, but also consult with intensive care for potential admission. You can give high flow nasal oxygen, NIV, and also invasive mechanical ventilation might also be required. It's worth saying that obviously we're learning about this all the time at the moment, so guidelines change, but at the moment, that's what BMJ best practices is saying. So, so what's important to think about in an elderly patient with a serious illness like COVID-19? They may not recover. It's really unfortunate, but despite our best efforts, they might not get better. Can anybody else think of any reasons why it's important to consider this in this patient?
DNA CPR?
Yeah, excellent. That's the main thing. At the moment, we don't know whether this patient has one in place at the moment, but it's really, really important to consider this at the moment, especially with advanced age and the other comorbidities that might make it harder to treat them. So what, if you were the doctor, what do you need to do? Who do you need to speak to with regards to if a patient doesn't have a DNA CPR in place? Who do we speak to?
Someone on the chat said relatives.
Yeah, it's really important to talk to relatives.
The patient as well?
Absolutely, absolutely. You need to speak to the patient. So yeah, so at the end, when you've spoken to people, explored how they feel about the situation, who makes the decision about a DNA CPR?
The doctors ultimately, they would decide.
Yeah.
The patient can't like demand it. They can only like refuse it.
Yeah. So at the end of the day, it's a clinical decision. It's up to the doctor to make the decision in the best interests of the patient. But you have to speak to the patient and their support, their family, wherever that might be, and you need to explain your reasoning why you feel like this would be important. Obviously, in this case, this patient has comorbidities that make mortality greater. They've already come into hospital. Their O2 saturations are going down. It'd be important to put this in place if possible, sooner rather than later. But of course, with everything you do, you have to do it with care, compassion, and empathy. At the moment, people are incredibly anxious inside and outside of hospital about COVID-19. And it's really important to remember when a patient comes in and they're elderly and they're frail, it can be really, really scary to see people coming in masks and visors and helmets. So make sure whatever you do it respectfully to the patient. Obviously, as medical students, we won't be doing this, but if you were the doctor, this is what you'd do. So yeah, that's everything that I had to say before everybody shoots off. I found this website that's really useful called Radiology Masterclass. They've got some like sort of short teaching courses on there that take you through X-ray interpretation of some really important pathology as medical students you should know about. So I definitely recommend you have a look at that. But yeah, that's everything.